The Geneva Health Forum invites you to attend its next edition from the 10th to the 12th of April 2018. The Digital Revolution and Public Health Practice, Impact and Consequences. The 7th edition of the Geneva Health Forum in Geneva from the 10th to the 12th of April in the presence of the main Swiss and international global health players. This year, a special focus on Central Asia, with invitations extended to the republics of Tajikistan and Kyrgyzstan, and with the Russian Federation as guest of honor. Digital revolution, global health, health security, access to essential medicine, chronic diseases, neglected tropical diseases. Geneva Health Forum 2018, Precision Global Health in the Digital Age. Networking, conferences, exhibitions in Geneva from the 10th to the 12th of April 2018.
Ladies and gentlemen, dear Peter Maurer, President of the ICRC, dear Dean Henri Bounamo, Dean of the Faculty of Medicine, University of Geneva, dear Jean-Dominique Vassali, former rector of the University of Geneva, but here as the president of the scientific committee of the Fondation Brochet, and we can say also president of the Fondation Privée des HUG, dear Professor Ezil Jones from the University of Manitoba, and dear Stéphane Couty, General Secretary of the Fondation des HUG. Dear colleagues, ladies and gentlemen, I am pleased to be the master of the ceremony of this closing ceremony after a vibrant Geneva Health Forum in its 2018 edition. Thank you to all of you who are still attending to this closing ceremony. We will try to make it as vibrant also as possible. And we will start by an award ceremony. There will be, I will say, 3 major sequences. One will be this award ceremony. The second one will be some announcement from our colleagues on some events and some courses also. We will have, after, a series of conferences, Brochet conferences, for the 100-year memory of the victim of the pandemic influenza, and 3 conferences chaired by Dean Bounamo from Jürgen Tinger from the Swiss Tropical Institute, and also from Peter Maurer from the ICRC. So, first of all, I call François Chapuis and colleagues for the first award ceremony, which is the Anne MAURER-CECCHINI Award. François.
Thank you very much, Antoine, and good afternoon to all. You start first, Guy.
Ladies and gentlemen, we created the Anne MAURER-CECCHINI Foundation in memory of our daughter, Anne, who had chosen to dedicate herself to research on neglected tropical disease. After completing her pharmacy studies, she worked with Professor François Chapuis on leishmaniasis, and later on with the Swiss Tropical Institute on an African trypanosomes project. After her tragic accident, we decided to carry on her engagement by supporting research on these diseases with a biennial attribution of an award. This year, we attribute for the 5th time the Anne MAURER-CECCHINI Award. As usual, Professor Chapuis chaired the scientific committee in charge of evaluating the applications, together with Madam Professor Marleen Bolhert from Antwerp, Professor Christian Bury from the Swiss Tropical and Health Institute, and Professor Simon Croft from the London School of Hygiene and Tropical Medicine. We thank them all for having accepted this task. For this year's award, we received 17 applications of high interest and quality, and 2 studies clearly emerged. We therefore decided to attribute 2 awards this year to 2 very different projects, one on neurocysticercosis and the other on human African trypanosomiasis, that both carry a huge potential to curb the impact of this neglected tropical disease. I now let Professor Chapuis present together with the authors of the awarded project.
Okay, yeah, stay with me, Guy. Indeed, 2 winners this year after a quite straightforward process. 17 candidate papers were reviewed by the 4 of us, but the final decision was made by the board of the foundation. So I'm happy to present the first winner. This is the team of Hector Garcia, Professor Hector Garcia in Peru, from the Peruana Cayetano Heredia in Lima. They have done quite amazing work on neurocysticercosis, one of the main cause of epilepsy in developing countries and several large areas of developing countries. This was a pilot project of an elimination schedule, and to present the project, there is a short video that is also available in the New England Journal of Medicine website, and then a short video also of the winner.
Taenia solium is a pork tapeworm that infects humans. Humans become infected after eating contaminated pork or through fecal-oral exposure. Larvae from the tapeworm eggs migrate to muscle and other tissues, including the brain, which can lead to neurocysticercosis, a major cause of seizures in developing countries. Can the transmission of Taenia be stopped on a population-wide level? Investigators implemented a 3-phase eradication program to eliminate Taenia solium from the villages of Tumbes province in Peru. Various screening and treatment strategies of both pigs and humans were conducted in the first 2 phases of the program to determine the most effective and practical interventions to implement on a wider scale. In Phase 3, over a 1-year period, mass treatment was given to over 81,000 people in 107 villages, and more than 55,000 pigs received treatment and vaccination. Humans received a series of 3 doses of niclosamide, with 85% of the entire population receiving at least 1 dose during the intervention period. Pigs received oxfendazole every 2 months, along with Taenia vaccinations. At baseline, the prevalence of pigs with Taenia seropositivity ranged from 25 to 50%. After 12 months of intervention, 3,530 pigs were randomly screened, and 29% were seropositive for antibodies. Necropsies were conducted on 342 seropositive pigs, and less than 1% were found to have live, non-degenerated cysts, as compared with an estimated prevalence of at least 20% before the intervention. Thus, Taenia solium transmission can be stopped on a population-wide level with mass treatments of both pigs and humans, along with pig vaccination. Full trial results are available at nejm.org.
And then a message from Professor Garcia.
On behalf of the Cysticercosis Working Group in Peru and myself, I want to thank the Foundation and the Scientific Committee for this honor. Our findings open the way for cysticercosis elimination, and we feel that this has not yet incorporated by decision-making bodies such as the Bill and Melinda Gates Foundation, who funded the study, and the WHO, and we hope this will contribute to raise awareness and incorporate cysticercosis elimination in their agendas. The project used a coproantigen ELISA as a key tool to detect tapeworm carriers. The funds of the award will be devoted to improve this test to make it field applicable, more available, and worldwide distributed. Thank you once again.
Thank you, Professor Garcia, as if he was live from Lima. There was a strong message, by the way, to WHO and the Bill and Melinda Gates Foundation. There were 2 winners, as we mentioned before, and we are happy to present the second winner of the MAURER-CECCHINI Award. This is a whole team from a study sponsored by the DNDi, the Drugs for Neglected Disease Initiative, led by a Congolese investigator, Victor Condé, and several others. This was published in The Lancet late last year. It's the first effective oral treatment for second stage, late stage sleeping sickness, which is a disease that affects predominantly the Democratic Republic of Congo in sub-Saharan Africa, and that leads to death without treatment. So as you can see, there are a few names that are underlined. There is also the last author that I'm happy to say, Antoine Tarral, who is present today, and the whole DNDi team is invited to come up to receive the award and say a few words. Please. Oui. De manière officielle.
D'accord. Voilà. Alors, je vais essayer de ne pas pleurer.
Avec de félicitations pour ces études, ces magnifiques études qui amènent beaucoup de bonnes choses.
Merci beaucoup. Merci infiniment. Voilà. Tiens, la maman. Thank you very much. I think we're very touched. I have to say it's quite emotional for us to receive this prize, which comes from a researcher in the field. So, and it also comes after a history of researchers working in sleeping sickness, Philippe Bucher, Gerardo Priotto, and others also working on neglected tropical diseases, which is the reason why we're here. This study was conducted in the Democratic Republic of Congo as well as in Central African Republic. We started in 2012. It was a long journey. We involved 10 clinical trial sites, and I want to acknowledge here on behalf of DNDi all our partners, starting with the National Sleeping Sickness Control Program, which is represented here by Dr. Ndigas Ngolo, who was the co-investigator for this clinical trial. We also worked with MSF. 2 clinical sites are run by MSF. We were helped by the Swiss Tropical Institute, that is represented here as well, and we had many other partners, including the Institut National de Recherche Biomédicale from Kinshasa. So the objective of this study was to demonstrate and to test whether an oral treatment for sleeping sickness could be close to the efficacy that we have seen with a highly efficacious standard reference treatment, NECT, which got the award a few years back, and to show its efficacy and safety in late-stage sleeping sickness. The objective is that this oral treatment could, in a way, change the paradigm of access to treatment for patients living in highly remote areas where they would not need to have infusions and, in fact, be treated in very specialized centers. So about 200 people worked on this study, so probably the size of the audience here. Every 200 people working on collecting the data, making sure they were of good quality, analyzing this data, and eventually publishing the data, which is why we are here. So the results were showing that we met what we were looking for, which was to show high efficacy of this oral treatment, 91.2% in very severe HAT patients. We also shown that the drug was well tolerated, and following this work, Sanofi, who is the industrial partner of the NDI, has submitted an application to the European Medicines Agency. The European Medicines Agency is currently working on assessing this dossier, and if everything goes well, the fexinidazole could be registered in DRC by the end of this year or early next year, which is, I think, a huge progress for patients. So I just want to finish by saying that since Anne was a researcher, we'd like to allocate, and a researcher looking at, high-level research, I think, we'd like to allocate this prize to our new product, which we are testing now, which is a one-dose unique treatment for sleeping sickness. And I would also like to thank, of course, the organizers for selecting us, but also our donors, some of which I can see in the room, including the Swiss government. So thank you very much, and thank you again.
Thank you, Guy Maurer. Thank you, François Chapuis, and congratulations to the DNDi. We are so proud to have such organizations in Geneva who make the change happening. So now it's time to give the awards of the Jet d'Or de Genève. Et nous allons parler en français et en partie aussi en anglais. Ces Jets d'Or de Genève n'auront peut-être pas toujours la chance d'avoir sur l'estrade les gagnants, parce que c'est vous et c'est le comité de programme qui les a attribués en direct, et on va les découvrir aujourd'hui. Et j'appelle Stéphane Couty, la secrétaire générale de la Fondation privée des Hugues, pour nous parler de ces Jets d'Or de Genève.
Bonjour, chers intervenants. Au nom du Conseil de fondation de la Fondation privée des hôpitaux universitaires de Genève, permettez-moi en premier lieu de vous féliciter pour l'excellence des échanges et des débats qui a marqué cette 7e édition du Geneva Health Forum. En parcourant vos posters, en lisant les publications, en vous écoutant dans ces différentes sessions, je me suis fait la réflexion que l'ère du digital est véritablement vertigineuse et nous expose à des quantités colossales de données issues de sources innombrables. Ces données, il faut les répertorier, il faut les analyser, il faut les comprendre, il faut les vérifier pour en extraire l'essentiel. L'homme mise sur l'intelligence artificielle pour l'aider dans cette vaste entreprise, ce qui génère en lui, en vous, en nous, une excitation incroyable dans la quête pour la connaissance. Pour autant, encore faut-il que cette nouvelle ère de la digitale favorise l'homme dans son humanité, que ceux qui peuvent entreprendre et innover le fassent dans un souci de globalité. Cette exigence a été très présente dans ce forum autour de la santé. Les innovations que vous avez présentées ont mis l'accent sur une recherche participative, sur des approches pédagogiques abordables à large échelle, des utilisations personnalisées et adaptées pour une plus grande efficacité, tous veillant à ne laisser aucune population en marge. La Fondation privée des hôpitaux universitaires de Genève soutient tous les patients et s'adresse à toutes les pathologies. Nous soutenons, grâce à la générosité de nos donateurs, des projets dont l'impact sera aussi bien national qu'international. Nous souhaitons ainsi suivre votre exemple en pensant santé globale en faveur de l'humanité. C'est donc pour moi un honneur de vous remettre ces 4 Jets d'Or de Genève pour 2 jeunes chercheurs, pour une innovation et pour une personnalité remarquable dans le monde de la santé globale. Je vous remercie.
Stéphane Couty va remettre le deuxième jet d'or de la Genève de la recherche. C'est vous qui avez choisi ces jets d'or, ces deux premiers jets d'or que nous allons remettre au meilleur poster. Donc le deuxième jet d'or, c'est le deuxième meilleur poster. Tous les posters étaient électroniques et vous avez pu voter pour. Et nous espérons que la personne que Stéphane Couty va révéler est dans la salle. Sinon, si quelqu'un la connaît et peut remettre le prix, nous serons également ravis.
Le deuxième jet d'or de la Genève de la recherche revient donc à Yu Zhao du World Health Organization de Genève pour son poster intitulé Open Who, Integrating Online Knowledge Transfer into Health Emergency Response.
Encore, restez encore, je crois qu'il refait une photo. Bravo.
Merci beaucoup, bonjour. Good afternoon, everyone. First, to clarify, this is not an award that contribute to myself. Actually, we submitted this poster on behalf of the entire support for response team under the WHO Health Emergency Program for the project that just started 9 months ago, aiming to help every health worker in the front line to provide them accessible and understandable knowledge during health emergencies. So this is a collaborative effort with the leadership of Ms. Heini Wutunen here, my supervisor, and also everyone, and Michael from here, and everyone in the team. So just to clarify. Very short introduction of the Open WHO platform. This platform was designed just after the reform of World Health Organization, really to design to address the issue of during health emergencies, the health worker in the front line could not find it very difficult getting access to the information that they need and they understand. So language issue and accessible issue. And 9 months ago, we started to, actually 1 year ago, we started to design this platform, specifically focused on serving the outbreaks and deployment people during emergency, with different channels focusing on infectious disease, social science intervention, including risk communication, community engagement, and humanitarian responses, such as risk assessment and operation preparedness and incident management system. We also have a big part of the trainings, online training courses that dedicate to the influenza preparedness work. So really wanted to collect the information and make sure that the users could find what they need during the next pandemics that is coming in the future. And so that's the vision that we want, really to push out the information. And the poster that we submitted basically is a validation of the knowledge resources during the emergency. Thank you. Trying to support the different outbreaks and translate the local languages. So here, if our colleagues from the NGO Translator Without Borders, thank you for your contribution as well. That without you, we could never ever able to translate every local languages within the 72 hours and push them into the community. And thank you everyone who voted for us, because without you, we will never be even closer to the community that we serve and the people we serve. Thank you.
Merci beaucoup. Le premier jet d'or de la Genève de la recherche est destiné, and the winner is, je lis ce qui est écrit, à Nadia Wells, Graduate Institute Geneva, pour son poster « 4 Challenges that Global Health Network Face ». Madame Wells. Madame Wells. Nous le gardons au chaud. Voilà.
The third jet d'or de la Genève de l'innovation has been designated by the steering committee of the Geneva Health Forum. Antoine Gesbuller, Nicole Rosset, Eric Comte, Noria Meslev, and myself, we studied the 96 innovation. In fact, 6 did not show up during the Geneva Health Forum. So in the remaining 90 innovations, we studied the innovation criteria itself, its capacity to provide or to help providing care, health care or health, and also its capacity to be implemented in a sustainable and affordable way. And so the best innovations, according to all these criteria, was very difficult to provide, because you have noticed that there were so many excellent innovations which were presented during these 3 days. But we had to decide, and so we decided.
And the winner is Health System HSO7, Kushi Baby, India, Mr. Shah Nawaz. Wearable ML Solution. Wearable ML Solution for maternal and child health at the last mile.
Congratulations. Keep it here.
Can you please take this?
Yeah, sure.
Thank you. Yeah, sure.
We need to give you that.
Thank you. Thank you, Geneva Health Forum. And this award we would like to dedicate to all the mothers and babies that we are tracking at the last mile. This is one of its kind project we have started as a classroom project in year 2014 at Yale University. And now, today we have crossed the 15,000 beneficiary mark, only today. So, and we are working in 375 villages in India, in Udaipur. And that the situation there is something which demands a patient-centric approach to track the maternal and child health. Thank you, Geneva Health Forum, for recognizing our effort, and thank you for inviting here.
We have just omitted to give the envelope with a check in it to the second prize for the research, Open WHO. So if you can come back, you will receive your gift from the Fondation Privée des HUG. So now it's time to deliver this premier jet d'or de la Genève, which is the Grand Jet d'or de Genève. Le Grand Jet d'Or de Genève est une innovation du Geneva Health Forum. Nous avons voulu couronner une grande personnalité de la santé globale et le comité de programme du Geneva Health Forum, constitué de l'ensemble des partenaires du Geneva Health Forum, a nominé 7 personnalités. Ces 7 personnalités sont Sally Davis, for her very strong leadership on antimicrobial resistance. In the opinion of the committee members, she has been the most vocal government official to advocate on AMR. Ruth Dreyfus, she has successfully implemented universal health care coverage in Switzerland. Also, drug policy based on prevention, therapy, help, and rehabilitations. She chairs now the Global Commission on Drug Policy since 2011. She co-chairs the UN Secretary General's High-Level Panel on Access to Medicine since 2015, and she chaired the WHO Commission on Intellectual Property Rights, Innovation and Public Health, 2003-2006. Jean Frémont, he has created an open forum for NGO leaders, academics, private companies, high-level representatives of UN-related organizations to exchange views and ideas on the most challenging issues on the health sector is facing at a global level. Joanne Liu, president of Médecins Sans Frontières, pediatrician by background, may represent the perfect spirit of the Geneva Health Forum, global health and humanitarian actions. She belongs to one of the major NGOs of Genève International, reflecting the civil society. Her own career, coming from a family of Chinese immigrants in Quebec, deserves the disrespect and admirations of the committee members. Jacques Madère, he has outstanding contributions to global health by advocating over the last 3 decades the essential role health system strengthening, primary care, human resource development, and have to address health inequality and progress to universal health coverage. He provided substantial contribution to global health progress, capacity building measures, health promotion and service projects, reducing the burden of disease of those in Asia and Africa suffering from infectious and non-communicable disease. Sheba Memandi, she may listen to us from California through Skype. She became the face of Chagas disease, both in the United States and internationally, what made her appear multiple times in local and national media. In recognition of her work and her dedication to stimulating research on Chagas disease and the screening treatment of patients, the committee had welcomed her nomination for this Grand Jet d'Or de Genève. And by alphabetical order, Marcel Tanner. The committee believes that his lifelong career and all his achievements have contributed to improve the health, in particular, of the most vulnerable people around the world, toward more equitable, sustainable developments. His endless awareness raising and fight against neglected tropical disease and malaria, his extensive field experience and diplomatic skills, as well as his human quality and boundless empathy, have convinced uncountable investors, researchers, politicians, and the public opinion to support critical but often neglected causes. We have voted, thanks to the tools of the Faculty of Medicine of the University of Geneva, and nobody knows today who was the winner in this room. And I let Stéphane Couty to tell us.
Except you. The nominee obtained his PhD on medical biology from the University of Basel and an MPH from the University of London. He was director of the Swiss Tropical and Public Health Institute from 1997 to 15, and continued as professor of epidemiology and medical parasitology at the University of Basel and at the Federal Institute of Technology until his retirement in 2016. Since 1977, his research ranged from basic research on the cell biology and immunology on malaria, schistosomiasis, trypanosomiasis, and filariasis to epidemiological and public health research on risk assessment, health impact, and district health planning. His expertise is based on substantial field experience in rural and urban areas in Africa, mainly Tanzania, Chad, Burkina Faso, and Côte d'Ivoire, and Asia, China, Thailand, Laos. He was co-investigator and coordinator of the first African malaria vaccine trial in 1992 and participated as a co-principal investigator in several major intervention trials on malaria and schistosomiasis. Besides research, the capacity building and North-South partnership were main interests as reflected in the development of the Ifakara Health Institute in Tanzania. He has published extensively in the mini field more than 600 original papers. Vous l'avez reconnu, the winner is Marcel Taenia.
Grand merci. Qu'est-ce que je peux dire? Je suis extrêmement touché et je vous remercie infiniment. Je vous remercie parce qu'en fait, c'est le prix pour tous de nous, parce que nous sommes dans le même bateau. We are in the same boat, and that's why this goes for all of us, because we have pursued for many years, not only just to do a research or just to do application in public health, but really to live this value chain from innovation to application. And most of you have been part of these efforts over many years. And so we can celebrate together this schedule, because it's really something which is a joint effort. And the Geneva Health Forum is one of these moments that marks how we move on together. And it's really wonderful that we can continue in this spirit for many years to come to really make a difference. And as some of you very well know, I come now with an old sentence, but that's the key sentence, is this mutual learning for change. How we learn together, not one helps the other, but we learn together to make a difference. Mutual learning of change makes the difference. And this partnership that is built on mutual learning for change will carry us very far and help us to really tackle the big challenges that we have in public health. So thank you very much, and let's move on together. Thank you.
Merci Stéphane. Je remercie aussi Beat Stoll, l'EPFL et la faculté de médecine qui ont fait ces jets d'or de Genève avec l'imprimante 3D de la faculté de médecine et les designers de l'EPFL. Il est temps maintenant de passer à la deuxième partie de cette cérémonie de clôture par quelques annonces. Et je vais appeler Thomas Maillard pour la première annonce qui concerne Open Geneva. Thomas Maillard.
En anglais ou en français?
Comme vous voulez.
Okay.
C'est traduit.
Okay, great. Hello, everyone. Thank you very much for having me here today. Open Geneva is a very young institution, started last year in collaboration with the Geneva University Hospital. We decided that it was really important for people all over Geneva to innovate hands-on and to also engage people abroad into innovation. Not only scientists, not only entrepreneurs, not only multinational, but taking the example of the hospital would be patients, nurses, physicians, administrative personnel, IT people, whoever are interested in making, for example, an hospital a better place. And we extended that as a festival open to any organization willing to organize what we call hackathons over Geneva or coming even from other places to join us for a long weekend of open innovation, an innovation for everyone, by everyone. And so Open Geneva actually started already on Monday, but it's going until the end of the week, and we get 30+ events of innovation all over the city. And actually, I want to say there are topics that might not look like they are related to health, but in fact, when you look at it very closely, you get really health everywhere. So let's take a topic of smart city. Well, many things related to smart city is about like having a better life. You get hackathon by Terre des Hommes on innovating for migrant youth. It's all about like well-being, making the migration and sort of less painful journey. And so what we want to do with this festival of innovation is really to gather together everyone in one place over a very short amount of time, like a conference like here, just that people get to do things together and to make together to achieve over 24 hours or 48 hours a prototype or a big idea that they can maybe continue together. So innovation is something collective that we have to do together, and I think it reflects very well with the recipient of the Grand Jet d'Or say, well, we have to do things together if we want to overcome hard problems. And Open Geneva is a still small startup in Geneva, but hopefully growing with collective power. So thank you very much for having me here today.
Thank you, Thomas. And good luck for this Open Geneva Hackathon. It's great. Now it's my pleasure to ask to Professor João Gabriel Silva, the rector of the University of Coimbra, to present now the World Health Summit regional meeting. You know that we have a close collaboration with the World Health Summit. I will be in Coimbra in a couple of days, and now we are very happy that you came today to present and introduce this meeting.
Well, thank you. I'm here to invite you to be next week. It's pretty close, since you are in the mood of discussing global health. It's a nice way of going on with discussions. Next week in Coimbra. Coimbra is a very old university, one of the oldest in Europe. It's one of the 5 that has been declared World Heritage by UNESCO, so there's also a lot of interesting things to see there. Very nice places to visit, but essentially I hope that you will be interested in discussing with us along the main topic of the conference, which will be global health in African countries. These 4 themes, managing infection disease in low and middle income countries, something that has also been discussed here, or touched here at least. Then governance for health equity and low and middle income countries. It's really a challenge to be able to have acceptable health services in places where infrastructure in general and organization is pretty unstable, if at all existent. And certainly also discussing opportunities and challenges in translating innovation into healthcare, always focused on what we call frontier medicine, in the sense that places where it's really difficult to have regular health support. And certainly biomedical education, because it has already been many times mentioned in this conference, we need to have professionals that are able of providing those services. You can get more details about the program in these two places, and again, be very welcome in Coimbra next week. Thank you.
Thank you very much again, Joan. So now I would like to present not really an event, it is more a training course. It is taught in English. It is a one-week medical school. We organize all the medical studies in only 1 week in Geneva. But it is not for doctors. It is for many of you in this room who work full-time in global health issues, but you are from another background, maybe a social scientist, or maybe engineer, lawyer, economist, and you would like to benefit from the brain of the doctor for 1 week. You would like to deliver a baby, of course, in a robot. You would like to make punctures. It will be at the Centre Interprofessionnel de Simulation of the Faculty of Medicine and the School of Nurse in Geneva, and you will be trained for 1 week by the best faculty members of the Faculty of Medicine of the University of Geneva, end of June. And now, Nicole, if I can call you for a conference which will be at the end of this month, of August.
Ah, voilà. Alors, je vais vous présenter une conférence qui détonne un peu par rapport à tout ce que nous avons entendu pendant ces 3 jours, puisqu'elle ne parlera pas de digital, elle ne parlera pas de dimension clinique, mais c'est un aspect important des hôpitaux, puisqu'il s'agit de gestion hospitalière. Donc, comme on le sait, c'est un aspect essentiel en termes de financement, mais aussi en termes d'organisation, de gouvernance de nos institutions. Et sans ces aspects-là, les hôpitaux ne fonctionneraient pas. Donc, c'est bien aussi de le rappeler. Donc, j'ai le plaisir de vous annoncer la 9e conférence francophone en gestion et ingénierie des systèmes hospitaliers. Cette conférence aura lieu donc à Genève du 27 au 29 août prochain. Et c'est une conférence qui est organisée pour cette édition par les HUG en collaboration avec l'Université de Genève, également le PFL, l'IMAD, enfin, un certain nombre de partenaires suisses et nos collègues européens. Le thème de cette conférence va porter sur les systèmes, les réseaux et les établissements de santé en quête de performance. Donc c'est tout un programme et je vous invite à venir y participer. Ce sera une autre thématique.
Merci Nicole. The next slide is about a course. I suggest there is a video, but I suggest not to, because we are a bit late in time, not to present the video now. It's a distance learning education course which will be delivered by the continuing education of the University of Geneva on the theme, the main theme of this conference. It will be in October. It will be done during 5 weeks. 1 day per week, and it will provide insight in the different domains we have studied here in the digital and social and human science and life science in global health. So it is time now to move to the third part of this ceremony, which will be, and I will give the floor to Jean-Dominique Vassali for presenting the Brochet Conference Series number 2.
Thank you, Antoine. in a paper which was published today in the journal Le Temps, Antoine Flao was quoted as defending, of course, the innovation in global health. He also made some allusions to the role of social sciences and humanities in those issues. And that's one of the reasons why I'm happy to be here. The second one is that Antoine also emphasized the specific role of Geneva in the Geneva area, the so-called Geneva Health Valley, in global health. And for those two reasons, I think the Brochet Foundation, which I would like now to introduce you very briefly, for those two reasons, the Brochet Foundation is extremely happy to be a partner in this Global Health Forum. And I thank Antoine for having suggested this partnership. The Brochet Foundation is focused on the issues of the ethical, legal, and societal impact of the progress in medical sciences, and it is a convening place which organizes meetings. It also is a place for people to come as visiting scientists, and in that sense, it has become, I would say, a very important place in this field of the ethical and societal issues of health worldwide. And it is a facility which is in Geneva, and in that sense, I think I would like to point out this existence to you. So I will, for the sake of time and on request of our president, of our chairman, I will skip a little movie, but just remind you what are the activities and the key figures of the foundation. I won't read them to you, but you can see that it's, over its 10 years of activity, the foundation has become really an important center of discussion, thinking, and debate on those issues that I mentioned, the LZ issues. In this context, as you might well imagine, historical aspects of the health issues are of great importance. They give us a perspective on what has happened, perhaps some perspective as what might happen to us. And in that sense, we are celebrating, as you well know, the 100th anniversary of the pandemic, the influenza pandemic of 1918-1919, which had the consequences which we will hear about. This pandemic was, I think, a very important event for global health issues. 100 years seems to be a long way ago. It's not such a long way. I have realized that my own grandfather died during the pandemic of 1918. So I'm not so young, but still, it has affected directly my own life and that of my family. To talk to us about this pandemic, we are fortunate to have today Eileen Jones. Eileen Jones earned her doctoral degree in history at the University of Manitoba in 2003, and she has been working since in history and specifically around the history of, let's say, medicine and life sciences. She has also studied the history of healthcare and of socialized medicine. In other words, she has a rather broad, very broad perspective on the historical issues of our field. Specifically, she has published on the influenza epidemics, and she's currently professor of history at the University of Manitoba, and we are very fortunate to have her today to give us an overview of what happened 100 years ago. Please.
Good afternoon. It's a great honor to be here with you today, and I thank the Geneva Health Forum and the Brochet Foundation for so generously inviting me. There we go. It is indeed difficult to be said to be celebrating a centenary of the most deadly infectious disease outbreak in modern history, which killed, we now think, at least 50 million people in almost every corner of the globe in a matter of short months in 1918 and 19. It's also difficult for public health practitioners to find any successes to celebrate in the history of the struggle against this disease. It was an outbreak stubbornly resistant to almost all containment measures, and a disease for which there was no effective medical treatment. Coming at the tail end of the golden age of bacteriology, the influenza pandemic challenged the narrative of public health and medical progress. But it also afforded the opportunity for debate and reflection among public health practitioners and highlighted the value of strong relations and trust between health officials, the state, and the broader community. And in Canada, the flu pandemic yielded changes in public health practice and in concepts through which infectious diseases should be managed in a modern context. Voluntary efforts led by private citizens were a common social response to influenza globally and provided valuable supportive care to the ill and to their families, far beyond the capacity of any public health programs at the time. Where voluntarism and mutual aid was strong, it provided some protection against the worst impact of the disease, and the value of non-expert interventions at the community level shaped post-pandemic thinking of public health experts, leading toward a greater respect for the value of cooperation in public health work. In Canada, influenza killed about 55,000 people in the fall wave of the disease and the spring wave, almost as many as those who had died in the First World War. And the disease was indeed embedded in war. Historian Mark Humphreys argues that by the fall of 1918, Canada was almost a completely militarized society, mobilized at state and societal levels to prosecute the war effort. The national rhetoric of commitment and patriotism was fraying by the fall of 1918, however. For example, there were riots against the conscription of young men into the military, and there was significant discontent among war veterans, many of whom were unemployed. Then in the fall of 1918 came allegations that the military was showing a callous disregard for the lives of soldiers by not responding appropriately to the flu outbreak. The conditions in which ill soldiers were housed were considered inhumane. Like in the US case, which has been so effectively documented in Carol Byerly's Fever of War, in Canada, influenza was spread through the population by what Humphreys calls the trail of infected armies. Alan Swedland has said that anthropologists try to tell big stories in small places, and historians, of course, often do the same. So I'm going to talk today mostly about the small place that I know best, which is the city of Winnipeg. For those of you who don't know where it is, I like this map. It shows us at the heart of the continent. Winnipeg's experience with influenza was about average for a Canadian urban centre. At the time, it was the third largest city in Canada, which it isn't anymore. It had crude death rates of about 6 per 1,000 population. But that average masked what appear to have been significant disparities between the economically secure and the poor. So we know that influenza, oh, sorry for the garbling there, influenza had differential impacts at the global level, within countries themselves, and within communities as well. Some of the statistics here are from across the globe, and we get some rough idea of the very broad range in mortality rates. Scholars like Anne Herring and Aaron Correll and others have argued, therefore, that flu was not a socially neutral disease. Their work on Hamilton, Ontario, illustrated in this slide, shows the impact of class and ethnic inequality on the concentration of the disease. In my own work, I have studied the impact of influenza, disproportionate impact on European immigrants and working class families in the city's north end, which is shown here in bold print in District D of the city, relative to District A, which was much less harshly impacted by the disease, just purely at a very basic statistical level. These differentials do pale, however, hang on. Oh, there we go. They do pale, however, in comparison to those between Aboriginal and non-Aboriginal Canadians. And according to the statistics in this slide, only Aboriginal people in Quebec came close to having rates similar to those of Canadians as a whole during the flu pandemic, demonstrating the impact of colonialism and ill health generally among Indigenous communities during the flu outbreak. So my paper today doesn't discuss Aboriginal experience, mostly because Indigenous populations in the region in Winnipeg had been dispossessed of their land through the processes of colonialism and the expansion of white settler societies. Winnipeg was an immigrant city, both in image and increasingly in reality in this period. And there was significant tension around immigrant health, especially among those considered foreign, that is, certain ethnic groups from non-Anglo-Saxon backgrounds. Frequently, the target of public health campaigns, anxieties about immigrant neighborhoods came into play during the pandemic, but not to the extent that one might have expected. When it was certain that flu had arrived in Manitoba in fall of 1918, the Provincial Board of Health met and declared the disease notifiable as a contagious or infectious disease. On October 11th of 1918, the Provincial Board Secretary, Dr. Fraser, suggested a number of actions that were now appropriate for local health authorities to help to curb the outbreak of the disease. And in addition to requiring the reporting of all cases, authorities had the power to take certain measures: the isolation of diseased victims or those exposed to the disease, the disinfection or destruction of bedding, clothing, dishes, and cutlery, the prohibition of any unnecessary gatherings about stores, street corners, or other public places. In Winnipeg, health officials led by Medical Officer of Health Alexander Douglas initially opted against compulsory isolation in hospital or against the placarding of infected homes. And the infected were rather asked to respect a voluntary period of isolation. And during the first month of the epidemic, the mandatory reporting of cases formed the backbone of their response to the disease. And it was their intention to pay particularly close attention to the progress of the epidemic in poor and immigrant districts of the city. And officials developed a system for spatially mapping the progress of the disease in the city. Winnipeg's health department initially argued that the placarding of houses, that is, putting up a sign that there were infected people living there, would be counterproductive because it would tend to make people unwilling to promptly report cases. So they were attempting to foster cooperation and a willingness to be treated in an increasingly terrifying set of circumstances. The health department employed education rather than compulsion in immigrant neighborhoods. And here, I'm going to go to this slide, an attempt, this is an English language illustration of the sorts of education campaigns that were mounted. On the 19th of October, Winnipeg announced measures focused specifically on the poor and ethnic North End. Means are being taken to educate the foreign residents, as was the terminology of the day, as to the grave danger in of delay in combating the disease. Literature printed in Yiddish and Ruthenian giving warning and advice will be distributed today. Now, this approach was not universally accepted. The provincial medical officer of health adopted an increasingly assertive public posture, accusing alien residents in rural Manitoba of concealing cases of influenza from the authorities, and insisting that the public should observe the strict letter of the law or face prosecution to the limit. As a provincial official, of course, he had the upper hand in a system that had delegated authority to the local level, but which held legal decision-making at the provincial level. On the 1st of November, as a result of pressure from the provincial government, a full placarding initiative was announced in Winnipeg by city health authorities. The decision to enforce stricter measures was taken in the context of a sudden rapid escalation in the incidence of flu. During the last few days of October, the daily number of those infected, and these are reported cases, the actual number was probably much higher. The number of reported cases suddenly almost doubled every day and then rose to nearly 300, 500, and then 600 new cases being reported per day by early November. So Fraser wasn't alone in arguing for more full exercise of state power to contain the threat of contagion, particularly from immigrant districts. According to the Winnipeg news media, medical men also began to view measures taken thus far as inadequate and to push for greater restrictions on public mobility. So public meeting bans, immunization campaigns, I can't discuss those here today, I have limited time, but public education, placarding, and temporary hospitalization, all of the measures that were open to public health officials had a limited effect. By March of 1919, Winnipeg had lost nearly 1,200 residents to the flu in a city of 185,000 people. And so this was certainly a moment of defeat for a confident and competent health officer and his department. So I want to move now to talking about, talking about volunteer responses, nursing and voluntary efforts. So as the epidemic reached its peak, meeting the need for medical and nursing care rather than preventive care became a focus and also almost an impossible challenge to meet. Several hundred emergency hospital beds were open to isolate and care for the sick, but care was also needed for those who were still in the community, not in hospital. There were a few child welfare and tuberculosis nurses who were seconded to this effort, but a major part of the work was done by volunteer nurses at organizations like this one, the Margaret Scott Nursing Mission in Winnipeg, which was a charitable agency. Nurses found entire families infected, which was a common pattern, both parents and children, with no one in the home who was well enough to provide even basic nourishment or hygiene. In the last 3 months of 1918, there were 1,380 home visits made by this Margaret Scott Nursing Mission alone to patients, and nearly 400 more in early 1919. The work of the trained nurses at the mission was assisted by community volunteers and by about 30 to 40 physicians who had also participated. In addition to the Margaret Scott Nursing Mission, there was a campaign run by about 650 women from Anglo-Saxon backgrounds, middle-class women largely, who had no formal training in nursing. They opened an emergency nursing bureau and several food distribution centers in the city. And those volunteer efforts built significantly on women's wartime mobilization, particularly the VAD, the Voluntary Nursing Aid movement. In the first week of November, there were about 160 volunteers operating out of the medical college, but at the time there were nearly 600 new cases of flu being reported every day. The coordinators of the Emergency Nursing Bureau project began to worry that there were limits to what they could accomplish with only volunteer help. And they lobbied the city, the government of the city of Winnipeg, to consider paying people to assist in flu relief. They argued many women and men who would be willing to help cannot afford to drop their means of livelihood at the beginning of winter and take on this work at the risk of their lives without remuneration. It was suggested by the nurses that if the city would guarantee reasonably adequate wages for people willing to help, but hindered by their circumstances, it would bring a stronger response. But these sorts of economic commitments were not made by local governments at the time. In addition to this Anglo-Canadian volunteer effort, immigrant and ethnic communities organized their own philanthropic projects. The Jewish community, for example, operated its own relief agency. Ethnic philanthropic women turned their attention, skills, and organizational infrastructures to the flu epidemic, providing supportive nursing care, food, clothing, and linens to affected households. Interestingly, almost no news of this ethnic effort entered the English language press. Similar supportive campaigns were mounted by labor organizations and by working class mutual aid groups like sick benefit funds, which might also give a family money if the breadwinner was too ill to work or had died. And this sort of economic support was not available from governments at the time. And such organizations also played a very important role in helping families to pay for a dignified burial of the dead. The availability of support and basic care for nutrition, hydration, and hygiene likely made the difference between life and death for many Canadians. Although this question is still under-researched, those who live in geographically or socially isolated contexts may well have been more likely to die from influenza if they had contracted it. Certainly there is evidence in the Canadian case that death rates were higher in rural areas than in urban, where resources were more limited. Sven-Erik Mamelund has recently suggested that geographic isolation played an important role in shaping death rates, particularly in Canada's north. Thus, influenza demanded a response not just from public health officials, but also from the broader community. And formal health infrastructures and programs were not sufficient to address the scale of this outbreak. In post-pandemic debates, we can see health experts reflecting on this reality, on the value of their relationship with the public and the limits of their own policies and approaches. The flu pandemic shifted the balance between public health precautions and the rights of the community to autonomy and freedom from coercion. In the post-influenza, post-war world, as Dr. T.H. Whitelaw, who was Edmonton's medical officer of health, concluded, a new sane and reasonable approach to managing infectious disease was essential. It is evident that no public health law, which has not the endorsation and support of the public generally, can ever be reasonably well enforced. Human nature cannot be altered, but laws can be, and it seems desirable that our regulations regarding quarantine should be revised in such a way as to secure the maximum cooperation of the community, including the medical profession, in their enforcement. Following the World War, we hear a great deal about cooperation in all lines of endeavor. Would it not be possible to secure a greater measure of cooperation by reorganization and revision of our public health laws along the lines of sane and reasonable regulations? And these views were echoed at the first post-war meeting of the International Sanitary Conference in June of 1919, against the backdrop not just of the flu pandemic, but also famine and epidemic disease such as typhus that had remained a problem in Europe. And this was a changed world. The President, in his address to the conference, referred to the 5 years since their last session as having seemed more like 5 centuries, and spoke of the need to repair the conscience of the world in the post-war era. The idea of erecting barriers against contagion was invalid, and the quarantine concept was an obsolete scientific superstition, one health commentator wrote. The British Ministry of Health commented in 1921 regarding flu, "There is no question of shutting the wolf out of the sheepfold." Andrew Mendelsohn has argued that a shift toward a more synthetic knowledge developed in epidemiology in the interwar period. Contagion itself was a contested concept, increasingly complex and organic. Isolating disease vectors was no longer a simple matter. The key disease containment concepts for the future were to be adaptation to local circumstances, overcoming public resistance through health education, and the elimination of the foci of infection at their precise points of origin. To conclude, for many years, influenza was referred to as the forgotten pandemic, forgotten in a public way and assumed to have been forgotten at the individual family level. Over the years, I've done research on influenza, like today, suggesting that almost everyone had a family member or a friend or relative who died during the pandemic. And thus, the forgotten nature of the disease, I think, is subject to challenge. With an outpouring of historical research over the past 2 decades, we now know a fair bit about how societies responded to this massive disease event, and we can follow its traces into the post-pandemic world. In Canada, the pandemic was an occasion for reflection and a renewed commitment to finding alternative strategies apart from compulsion, segregation, and the restriction of individual rights, a direction health officers in Winnipeg had already begun to take. Influenza was, by all means, humbling, but it was also an event that shaped 20th century public health discourses. Thank you.
So, ladies and gentlemen, it's now my distinct privilege to introduce the next two speakers of this closing ceremony. The first one will be Professor Jörg Utzinger. He is trained in environmental sciences from the Polytechnical School Zurich, epidemiology, a PhD at the University of Basel, and demography from Princeton University. Since mid-2015, he is the director of the Swiss Tropical and Public Health Institute, an associated institute of the University of Basel. He is also a professor of epidemiology at the same university. His research, teaching, and training interests pertain to the epidemiology, diagnosis, and integrated control of schistosomiasis, soil-transmitted helminthiasis, foodborne trematodiasis, and other neglected tropical diseases. Other research and teaching interests include health impact assessment of large infrastructure projects in low and middle income countries. Professor Utzinger is engaged in transnational global health research consortia with ongoing collaborative projects in Ivory Coast, China, and many other places in Africa and Asia. He serves on the editorial board of parasitology and tropical medicine journals and advises national and international organizations on global health issues. Professor Utzinger, please.
Thank you very much. I also would like to thank Antoine Flau. When I asked him what I should talk, he said free range. So Antoine, the question, are you ready for that? Good. What I would like to share with you are just a few thoughts. In the program, it said that this Geneva is the global health valley, and I can approve. I arrived in Geneva, and there was this giant worm on the lake of Geneva. So I congratulate you. Indeed, this is the health valley. Now, also on the train, I then quickly studied the program. And again, there is this notion of the Lake Geneva region as the Swiss health valley. Antoine, I come from Basel, also another hub of health. But of course, you talk now a lot about global health. And we thank you really very much indeed now for these 3 days. It was already when coming, you see, nice sunrise along the lakes. So I start to understand that this Lake Geneva Swiss Health Valley indeed has a lot to offer. Now, maybe just a few personal words. I got to know Antoine a couple of months or years ago, and recently we were able to bring him to Côte d'Ivoire, and that's of course also one of the brief foci I will focus on. And you see, he even got a t-shirt. This was just a month ago, and I really like it because it says together. And this is, I think, also a very good spirit of this conference, that together one can do things. And you will also see this is a few of the thoughts that I would like to share with you. One, it was mentioned very prominently also now by the recipient of the first Grand Jet d'Or de Genève, that this is all about partnership. So I will just try to delve a little bit into this issue. And the other one, already in the program, that there is this claim that the digital revolution indeed transforms how we practice global health. So I would then like to just challenge a bit, is it as simple to make now this combination of the life sciences, the social sciences, and also the data sciences? And finally, then just a few of the promises that are made, and therefore also some of the opportunities. Innovation, probably one of the terms we have heard now for 3 days on a probably once a minute basis. Data, big data, and I will also try to bring another element in, which is emotions. So the first thing, it was said, this is all about partnership. As you know, Switzerland has a couple of hubs in the global south, where indeed great partnerships have established more than 50, more than 60 years ago. Here is just an example of the Centre Suisse de Recherche Scientifique in Côte d'Ivoire, near Abidjan, a center that was built up in the 1950s with a really simple mandate to improve, at the end, also people's health, to provide insight into conservation biology, quite a broad area, and it has remained up to today, is now in hands of Ivorians and has become a major research center. So basically, from a field station initiated by a couple of pioneers in Switzerland, this has then over time transformed into a research center. And this is characterized by a broad portfolio of activities, by specialized laboratories, so really a hub where local people in collaboration can pursue state-of-the-art research, translating the research into public health actions and conservation biology, you name it. All done according to partnership principles. There were specific sessions also now in the Geneva Health Forum exactly dealing with these issues. Now, also just really to highlight you what is the impact then of such a small dedicated research center, we have recently looked at just the scientific output of the entire country, Côte d'Ivoire, over the past 15 years. This was a period quite difficult. Côte d'Ivoire went through a civil war, so the universities, for example, were closed for 2 full years. And you see the first thing, nevertheless, the number of peer-reviewed publications in the Web of Science, for example, has increased from about 80 in 2000 to more than 200. Secondly, and I think that is even more interesting, the research has become much more internationalized. In 2000, about 40% of the papers had people from outside Côte d'Ivoire. If we look at the participation of authors now, about 70% are from the outside. So indeed, transnational consortia, internationalization of research plays a hugely important role. What I also would like to highlight, this very small research center with about 30, 40 senior scientists contribute to about 20% of the national research output from an entire country. So dedicated input, very focused funding, working in collaboration makes an impact on a national level. So again, I think one of the points really mentioned and I think lived in these 3 days is this issue of partnership. Now, second thought, this is really this digital revolution. A man somewhere in rural Sudan, you don't see any infrastructure, but at least he has his cell phone, and indeed that is in many of the places one of the items with which you have access to the world. But I would also then put that in context. If you have then a local scene like here, where people still do their washing of the clothes of the children and so forth at open water sources, this is a challenge. Here, clearly a risk of multiple diseases. So until the digital revolution really hits these communities, I think we should not try to oversimplify. And this is what I want to just highlight now with one specific example, and I have of course selected schistosomiasis as a tropical neglected disease, a disease affecting the poorest of the poor. You see here once again the life cycle, so people are the definitive host. they contribute through their behavior to the transmission of the disease, excreting eggs. These eggs are then reaching an open freshwater body, infect the snail, in the snail a multiplication, and then when people get in touch with the water, they become infected. Now, the claim is, with combination of life sciences, social sciences, and the data sciences, we make a contribution so that we are able to control, maybe eliminate the disease. So that's what I just want to highlight and maybe also challenge a little bit. In terms of the life sciences, clearly we have made huge progress in discovery, developing new drugs, diagnostics, vaccines. For schistosomiasis specifically, we have a highly efficacious drug. We have now new point-of-care rapid diagnostic tools, not yet the vaccine, but clearly major progress being made. We know the full genome sequence of the parasites helps us to identify new drug targets, vaccine targets, and of course also in terms of approaches for risk profiling, the life sciences have helped us a great deal. So in terms of life sciences, of course, progress made. Social sciences equally. There is possibility to do direct observation, the whole armamentarium from the social sciences. And you see, for example, if you do then observation in such a scene, again, where people live in poverty and they don't have running water at home, don't have sanitary facilities at home, of course, here is the question how this revolution really reaches these people. Finally, in terms of the data sciences, we have made great progress using remote sensing, being able to measure almost in real time at very high spatial resolution different potential predictors of a disease, be it demography, economics, environmental features, socioeconomic features. We have really developed a lot of tools that help us. Also then in terms of statistical analysis, mathematical modeling, to make rapid prediction, again, almost in real time. It's not easy. It needs very sophisticated, good, trained people who bring this together, but clearly major progress being made. And I just show you one example now on a continental level, the risk map in Africa for schistosoma hematobium and schistosoma mansoni. This is for the period 2000 onwards, based on a systematized review of the literature, geopositioning, using sophisticated modeling. You can basically then spell that out at country level, at district level. So basically, you have operationalized what are the annual treatment needs. So here I will clearly say, bringing together the different sciences, we are able to provide more accurate data. The question then, of course, is whether implementation, the responses follow. This helps us to estimate treatment needs for the school-aged population and so forth. And also, we are able, with these tools, to measure progress over time. Often, we want to see the impact of interventions, of our global health interventions. And here is an example. When we compare the situation of schistosomiasis in sub-Saharan Africa for the period 2000 to 2010 versus now the latest period, 2010-2017, you see we are able to say there was a reduction of more than 60% of children being infected with schistosomiasis. Hugely important to then also make a point for furthering drug donations, large-scale control programs. So bringing that together, a lot of promises, but still also many challenges. Mentioned one of the key buzzwords in the past 3 days is innovation. I would, of course, not challenge that, but would also clearly highlight, Marcel also mentioned it, the innovation is only then useful when you also validate it in real-world setting, and finally, you apply these novel tools. And don't just assume that whatever tool you develop works in a different setting. So it needs this rigorous process of validation before you are able to apply it on a larger scale. And another issue, not much discussed, but clearly also huge potential, is the reverse innovation. Just one example, schistosomiasis diagnostics, tools that have now developed and marketed in Africa are coming back, are being useful for the migrants coming to Europe, and this helps us even to save cost in our health systems. Second one, data, was also clearly one of the most utilized terms. Everybody talks about data, talks about big data. I would then also say, and this was discussed in a large extent, what is the access to the data, what are the policies for data sharing, how do we link the data? We talk about data from different domains, data curation, all really big issues. So big data, big issues, and this really needs time, needs good work together, and probably one could again here say, okay, there is an obsession of collecting and more data, but what is really essential to have then an effective global health program? And finally, this is an issue which was not largely discussed. It is, and I think also important in these kind of global health gatherings, and also when you pursue global health, that you should bring also emotions in it. It cannot all be done by artificial intelligence. At the end, it's human beings. So I was just... Just a few days ago in Côte d'Ivoire, you have seen the place where the Centre Suisse was created in the 1950s. For the first time ever, a federal councillor came and visited the place, and there was green pasture. Probably he felt like at home on the Rütli-Wiese, and it overcame him, and then there was the Swiss hymn. But I really think these emotions also play a hugely important role, and for those from the Geneva scene, you might have seen also quite a number of people from Geneva, so everybody, I think, quite enthusiastic. And that brings me to the end. I had prepared one final slide. I did not know whether or not I can show it, because I knew one of the nominees of the Grand Jet d'Or was Marcel, and finally, some more emotions. So Marcel, also from my end, deepest congratulations, and really a person doing terrific public health with a cigar. I think that also gives some emotions. Thank you very much.
I'm not sure the cigar was the best symbol for this closing ceremony, but whatever. I'd like to introduce the second speaker, Ambassador Dr. Peter Maurer, studied history and international law in Bern. In 1987, he entered the Swiss diplomatic service, where he held various positions in Bern and in Pretoria and then in New York. In 1996 as Deputy Permanent Observer of the Swiss Mission to the United Nations. In 2000, he was appointed Ambassador and Head of the Human Security Division in the Political Directorate of the Swiss Department of Foreign Affairs in Bern. In January 2010, Mr. Maurer was appointed Secretary of State for Foreign Affairs in Bern and look over the Swiss Department of Foreign Affairs with its some 150 Swiss diplomatic missions around the world. And then he succeeded Jakob Kellenberger as International Committee of the Red Cross President on 1st July 2012. Under his leadership, the committee carries out humanitarian work in over 80 countries. His priorities for his presidency include strengthening humanitarian diplomacy, engaging states and other actors for the respect of international humanitarian law, and improving the humanitarian response through innovation and new partnerships. Dr. Maurer.
Well, ladies and gentlemen, colleagues and friends, I have promises and emotions, but no PowerPoint. So it's only the word. The promise is that I am the last obstacle between you and the happy end of the meeting. But let me just make a few comments, first and foremost from my side, to appreciate the enormous richness of the program, which, of course, for the ICRC is of high relevance because we are operating and faced in many places in which we are, in the fragile context in which we operate, with exactly the serious health challenges that you have been discussing today. And we have been confronted over the last couple of years, not only to scale, but also to innovate our health response, because the gap between what is needed and what we are able to do is increasing in many of the places in which we operate. I wanted at the end of this meeting maybe just to make a few comments on the scope of the issues we are facing today, our response, and then on coping mechanisms and future directions. Let me just first say that my organization is probably one of the most exposed to the paradoxes of progress. More people than ever are healthy, wealthy, educated, and connected worldwide. But where we work and what we see is that numbers of people in need of humanitarian assistance, in particular of health services, are spiking. Systems are failing apart. Health is the most prominent and visible, where the impact on violence and conflict has devastating effects. Water, waste, sanitation, education, and all other systems are similar to what we see in the health sector. In Yemen, for instance, less than half of the health system is operating today compared to the pre-war. 16 million Yemeni today, out of 27 million population, require assistance to access to healthcare, including a staggering 9.3 million in acute need. There have been more than 160 attacks on hospitals, clinics, and medical personnel since the beginning of the war in 2015. Normally preventable infectious diseases such as cholera, diphtheria, and measles have re-emerged. Medical staff are not being paid. Those with chronic illnesses are not receiving treatment, leaving thousands at risk. In Syria, where I just spent, as you may have seen, in eastern Ghouta, the impacts of drastic shortages of medical supplies and equipment I have seen are dramatic. I heard from medical workers who reported that hundreds of sick and severely wounded people are deprived from life-saving medical care, and they're just dying by high numbers. In some areas of Iraq, despite the fact that the big battles are over, more than 45% of the health professionals have fled the country. Today, symbols of medical protection and assistance have been desecrated. Medical facilities and workers are under the threat in many countries of the world, from Africa to the Middle East to Asia and Latin America. Combining ICRC's experience at some of these front lines of wars and violence, you have heard us say for quite some time that when health facilities, doctors, ambulances are deliberately attacked or destroyed in war and by violence, systems fall apart over time. And these impacts on systems are computed in protracted conflict, complex and long-term conflicts. As wars are often fought in cities, urban situations are particularly exposed to these issues. Then health systems cannot cope with emergencies, preventable infectious diseases and epidemics. And additionally, massive population displacement compound these situations. For example, people with chronic conditions such as diabetes and hypertension living in humanitarian crises are 2 to 3 times more likely to suffer a decline in their condition. And the erratic treatment of communicable diseases such as tuberculosis not only prevents recovery, but lead to multi-drug resistances. In short, war violence not only have a direct impact on the wounded and sick, as it is called in the Geneva Conventions, but have massive indirect impacts, and so war and violence become today, with the extent and the depth of crises, a public health issue. Saying a few things on coping mechanisms and response. Let me just start with an assertion which I do in each and every speech I do, that as we deal with humanitarian work and crises, we have to recognize that public health issues from war and violence cannot be dealt with as public health issues. They need political solution first and foremost, and enhanced effort to solve the conflict which feeds those public health issues. At the same time, we recognize that we need to step up our protection work, which is outside the scope of a health response in crisis. And you probably have seen us increasingly engaged in bilateral, multilateral discussions with belligerents on the conduct of hostilities, on the respect of international humanitarian law. We urge humane treatment of detainees because we know that, again, detention facilities are a breeding ground for big health challenges. We propose more serious vetting of partners in alliances warfares today. We see that responsibility is declining on even discussing international humanitarian law's respect. We support training of belligerents. We strongly recommend more responsible arms transfer. We talk to influence and belligerents to ensure respect for international humanitarian law. We try to enhance negotiating skills of our people on the ground in order to create safe space for health and other humanitarian operators to respond to the crises. And you may have seen also that we have adapted our health strategy considerably over the last 4 years, moving from a focus on the direct impact of health to a much more focus on a public health response in fragile context and to a continuum of care, which is today an important template under which we look at all these issues. If I look today, and I mentioned it at the beginning, one of the key challenges we are confronted is the increasing gap between the demand on our institution and our capacity to respond. So innovative solutions become a key panacea, not a key panacea maybe in finding final solution, but they become a key avenue to charter in order to close the gap. With the Swiss Tropical Public Health Institute, we are rolling out a new tool that uses clinical algorithm to help medical staff diagnose common childhood illnesses. Importantly, the tool can be integrated effectively into the existing local health system. So we hope, for instance, that by the end of the year, the tool will be in use in more than 100 clinics in Nigeria. Next week in Copenhagen, I will launch a new partnership with Novo Nordisk and the Danish Red Cross to improve access to care for patients affected by diabetes and hypertension in humanitarian settings. We hope this cross-sectoral partnership will set an effective precedent on future collaboration models of similar nature. In the area of physical rehabilitation, we are using technological advances to improve patients' outcomes. In Lebanon, with the Beirut Arab University, we are exploring how virtual reality can improve balance training for lower limb amputees. Collaborating with EPFL in Lausanne, we are developing a new prosthetic foot which not only has great functionality, but is more cost-efficient than the products we have used in the past. We are also realizing the need for innovative financial solutions on health issues. Last year, you may have seen, we have launched the first humanitarian impact bond, which has raised 26 million in order to build physical rehabilitation centers in Nigeria, Mali, and the Democratic Republic of the Congo. You have discussed the digital world and health response and public health during the last couple of days. As we develop our next institutional strategy, we also ponder on how we want to foster more prominently novel technologies and digital transformation to find better health responses in humanitarian system. We want to have better access and proximity to patients by expanding our capacity to complement physical with digital access. We think that the future will not be only about accessing people, but also of being accessible to people and being able to service virtually also some of their critical needs. We have started also to harness big data capabilities relevant to health services, from understanding migratory patterns, also to understanding the pattern of attacks on healthcare facilities. We are preparing for a comprehensive personnel data management system with adequate encryption that may be used across health service providers or national boundaries to enable continuity of care. And we are, and I think you are, much aware of some of the dilemmas and challenges that digitalization is offering, in particular also in the health sector. Let me just mention 4 brief points. I know some of them have been the object of important debates over the last few days. We will have, over the weeks, months, and years to come, concentrate our efforts to further discuss the ethical boundaries of digital healthcare. We will have to discuss the adaptability of digital solutions to the context in which we operate, because many of the high-tech digital solutions are designed for consumer demand and highly industrialized countries, so the adaptation process is something on which we need to focus on. We'll have to discuss the privacy and security of data collection. Associating data with digital identities inevitably creates issues of privacy and security. Are we able to provide health services to people in person or digitally while protecting potentially sensitive patient information? A big issue to discuss in the future. And critically, the need to build both trustful relationships with people and to build trusted technical solutions for people to reliably and securely use. I think these are 4 challenges which come to my mind also when I see the big issues that you have discussed. Deliberately, the ICRC has taken a view that Switzerland and Geneva is an important place to be. So Mr. Rutz will see I mentioned Switzerland and Geneva, which includes Basel. Not first and foremost because of the availability of high-tech community with which we can drive the digital transformation of humanitarian and health response, but rather as a place where the legislative framework for data protection, research, innovation capacity, immunities and privileges for an actor like ICRC, to be very frank, and financial support for innovation go hand in hand and create an interesting perspective for health and more generally humanitarian responses to develop in the future. The ICRC is therefore member of Digital Switzerland, partner of École Polytechnique Fédérale in Lausanne, a strong partner of many of you here in the room and many of those who have participated in the Geneva Health Forum, and we look forward to continuing our exchanges, our reflections, and our cooperation in the future and at the next Geneva Humanitarian Health Forum. Thank you very much.
So, ladies and gentlemen, as the last speaker today, my main task, if not only task, is to catch up the time that was lost before. Unfortunately, the time that was allotted to my concluding remarks was quite small, so I can't do miracle, but I'll do my best. So let me close this 7th edition of the GHF, which held its promises. Rich, various and animated debates leading to projects, partnerships, and innovation. This year on global health in the digital age. I'm extremely pleased that the tradition of the GHF is continuing over the decades, and I am sure it will be the case for the years and the editions to come. I am shortening by 50%, and I am continuing. I have no time to thank everyone who participated to the organization. But I'd like to mention here the République et Canton de Genève, the Direction du Développement et de la Coopération of the Swiss Confederation, and the ICRC for their faithful and substantial support. The international organizations also, like WHO and Médecins Sans Frontières, for example, but also many members of the program committee who met regularly these last months to ensure the success of these journeys. Many thanks also to all the sponsors who are supporting this initiative. Last but not least, I have to express my warm thanks to the 3 co-chairpersons of the GHF 2018, Antoine Flahaut, Nicole Rosset, and Antoine Geispuller, with their operational team, in particular Mr. Eric Comte and Mrs. Noria Meslev. Finally, I'd like to thank our students, the so-called volunteers. I hope they were indeed volunteers, who generously accepted to write some comments on blogs, to tweet during the sessions, and to interview the experts along these days. Thanks also to all of you for your patience today, and also for your active and participation during these days with the spirit of the Geneva Health Forum. Please be back in 2020 for the 8th edition, and have a safe trip back home, or enjoy Geneva tonight and tomorrow. And I am inviting the 3 co-chairpersons of this meeting to come up to the podium to receive your congratulations and thanks for what they prepared for you. Please.
Thank you. And I think it is time now to say goodbye. Have a safe journey back to your home, sometime far from here, and book in your agenda the next Geneva Health Forum in 2020, March 23, 27th.
Ah bah c'est super ce que la discussion, on est quasiment 3 quarts d'heure de retard.
Bah non, on est 6 heures.
Oui, mais